You're staring at a board exam question. A transplant patient presents with new onset hypertension and kidney injury. Is the culprit cyclosporine or tacrolimus? They sound nearly identical, and their primary mechanisms are the same. Relying on rote memorization for pharmacology tables is a fragile strategy. Under the pressure of a high-stakes exam, that recall often fractures. We can avoid that panic by taking these abstract chemical names and physically mapping them onto a unified biological architecture. This turns a memory test into a predictable logic puzzle. Mastering the T-cell life cycle provides a spatial anchor for the data. While some toxicities flow logically from a drug's location in the cell, others become much easier to manage once they are categorized into distinct functional pairs. This is our canvas, a single T-cell waiting to be activated. Our goal is to shut it down. We target 3 operational zones: the IL-2 signaling axis in the nucleus, the nucleotide assembly lines in the cytoplasm, and the receptor blocks on the surface. Every drug on the syllabus acts as a physical roadblock within one of these zones. Let's start building the map. Let's zoom into the nucleus for our first critical node. Normally, an enzyme called calcineurin triggers the transcription of interleukin-2, or IL-2. That is the essential signal a T-cell needs to activate. By shutting down IL-2 transcription, we stop the immune response at its source. Cyclosporine and tacrolimus, the calcineurin inhibitors, form this exact roadblock. They are first-line agents after organ transplantation, primarily used to prevent graft versus host disease. Because their mechanisms are identical, board exams will strictly test you on their distinct side effect profiles. Categorize tacrolimus as the metabolic and neurotoxic cousin. As the mnemonic suggests, tacro is toxic to organs. This list includes nephrotoxicity, neurotoxicity, hypertension, hepatotoxicity, and hyperglycemia. It also causes hyperkalemia. Contrast that with cyclosporine's unique signature toxicities. Think cyclo for cosmetic changes. Here you are looking for hirsutism, gum hyperplasia, hyperlipidemia, and hyperuricemia. When you see a patient in a clinical vignette, check their symptoms. If you see failing organs and metabolic spikes, it's tacrolimus. If you see overgrown gums and extra hair, it's cyclosporine. Now we follow the signal out to the cell membrane. Even if IL-2 is produced, the T-cell must respond to it via the mTOR pathway to proliferate. We can place a second roadblock here to intercept that survival signal. Everolimus and sirolimus are the mTOR inhibitors. Because they act downstream of the primary signal, they are typically used as second-line transplant drugs. The most important side effect to lock in for this class is hypokalemia. This creates a predictable contrast. Calcineurin inhibitors push potassium up. mTOR inhibitors pull it down. That distinction alone identifies the drug in many transplant pharmacology questions. We now shift to the cell's internal factory, the nucleotide assembly lines. To divide, a T-cell requires massive amounts of DNA, which requires synthesizing purines and pyrimidines. We can shut down the purine line directly. Azathioprine, the prodrug of 6-mercaptopurine, and mycophenolate target this pathway. Mycophenolate specifically inhibits inosine monophosphate dehydrogenase. It's a powerful first-line agent, though it often causes significant GI upset. On the opposite side of the factory, leflunomimide blocks dihydroorotate dehydrogenase, shutting down pyrimidine synthesis. These drugs share a common goal. They starve the cell of the raw materials needed for DNA. Because they attack cellular division at its root, their side effects extend to every other rapidly dividing cell in the body. You can deduce their shared toxicity profile from this fact: systemic bone marrow suppression and hepatotoxicity. Finally, we zoom to the cell surface to categorize targeted biological agents. These act as specific caps for various CD receptors. They frequently appear as one-liners. Belatacept blocks CD80-86, alemtuzumab binds to CD52, and belamucidil acts as a Rho kinase inhibitor. The most critical pairing to distinguish on the surface is Basiliximab, which blocks the CD25 IL-2 receptor, and Muromonab, which blocks CD3. The distinction is purely clinical timing. Basiliximab is used strictly for the prophylaxis of acute graft rejection. It is given before an issue occurs. Contrast that with Muromonab, which is a rescue agent used to treat active acute graft rejection. Because it is deployed during an active immune crisis, it carries a high risk of causing rebound hypertension. Confusing the prophylactic purpose of Basiliximab with the active rescue role of Muromonab is a common way to lose points on clinical vignettes. Thalidomide and its derivative, lenalidomide, are versatile outliers. They are used to treat a wide range of conditions, including rheumatoid arthritis, multiple myeloma, and graft versus host disease. Its presence on your exams stems from its dark history as a potent teratogen. It causes phocomelia, a severe birth defect characterized by shortened limbs. To answer complex questions on its pathology, you must trace the specific biochemical chain. It begins with thalidomide binding to cereblon, disrupting tubulin. This disruption splits into two parallel effects. It blocks vasculogenesis and causes a massive spike in free radicals. These two corrupted pathways converge to halt fetal organ development, resulting in the physical presentation of phocomelia. Memorizing the specific cereblon to tubulin chain is the most reliable way to navigate detailed teratogenicity questions regarding this drug. Let's step back and look at the completed map. By placing every drug where it actually acts, the cell's own biology organizes the data for us. On the IL-2 signaling axis, first-line calcineurin inhibitors block the signal and push potassium up. Second-line mTOR inhibitors block the response and pull potassium down. Inside the cell, the antimetabolites, azathioprine, mycophenolate, and leflunomide, all starve the nucleotide assembly lines, leading to predictable bone marrow and liver toxicity. And on the exterior membrane, remember the timing. Basiliximab prevents rejection, while Muromonab treats it. Mapping these drugs to a structural architecture upgrades your prep from fragile memorization to a robust, systematic understanding of pharmacology. Retain this structural map as your primary framework for your upcoming board prep. Hit like and subscribe for the rest of our high-yield pharmacology series, and drop a comment with the next medical topic you want visually deconstructed. We will see you in the next one as we continue turning chaotic data into clean, predictable frameworks.